very good evening, and once again I bring greetings from UCMS and GTB Hospital and also from the Foxy MTP committee, and I will be covering hypertensive disorders in pregnancy. Please change the slide. Can you give me the control, Malti ji? Okay, so we all know that hypertensive disorders of pregnancy, it is one of the leading cause of maternal and perinatal mortality and morbidity. And globally, if we see, then the preeclampsia, it complicates 2 to 8% of the pregnancies. And in India, it complicates 8 to 10% of the pregnancies. And predicting and preventing preeclampsia is very, very challenging situation. And globally, it has been found that nearly 76,000 women, they die of preeclampsia each year. The number may be even more than that. And even 500,000 babies, they die of preeclampsia each year. So the situation is very bad, this thing, and it is very important for us for the timely recognition and intervention in cases of hypertensive disorders and especially the preeclampsia. Please change the slide. So what is more alarming in preeclampsia is that a woman who has suffered preeclampsia, her life expectancy is decreased by 10 years, especially if she delivers before 37 weeks of pregnancy. Now, the hypertensive disorders, we can classify broadly into various categories. So that is gestational hypertension, then chronic hypertension and chronic hypertension with superimposed preeclampsia, then preeclampsia with severe features and without severe features, then eclampsia and HELP. Now, preeclampsia can also be further classified as early onset if the delivery is required in less than 34 weeks, preterm preeclampsia if the delivery is required less than 37 weeks gestational age. Late onset preeclampsia is when the delivery is required after 34 weeks, and term preeclampsia if delivery is required after 37 weeks. Please change the slide. Now, the entire pathogenesis of preeclampsia, it is a very complex procedure which involves the multiple organs. Now, if we see the normal implantation, now we know that in normal implantation, the trophoblasts invade the decidualized endometrium, which lead to spiral artery remodeling and obliteration of tunica media of myometrial spiral arteries. Now, all this allow the increased blood flow to the placenta. And all these things are independent of maternal vasomotor changes. But in preeclampsia, what happens? There is the abnormal trophoblast invasion before many women know that they are pregnant, and long before the clinical manifestations of the disease become apparent. So here what happens? The trophoblasts, they fail to adopt the endothelial phenotype that lead to impaired trophoblast invasion and incomplete spiral artery remodeling. The resultant placental ischemia leads to increase in the angiogenic markers like soluble FMS like tyrosine kinase 1 and soluble endoglin. Now, these angiogenic markers, they bind to and decrease the levels of vascular endothelial growth factors and placental growth factors. Now, this is important. These are the important mediators of endothelial cell function, especially in the fenestrated endothelium, which are present in the brain, liver, and kidney. So this entire endothelial dysfunction occurs in the maternal vasculature, and this leads to the cascade of the complications. Change the slide. Please change the slide. Now, coming to the each entity one by one. Now, gestational hypertension, we call it if the hypertension is present, which means if the systolic blood, please go back to the previous slide. Previous slide. Back, previous slide. Yeah, thank you. Next slide.
इसके बाद वाली.
Can you give the control to me, Malti? Okay. So gestational. Okay, ma'am. So gestational hypertension, if the hypertension is present, which means systolic blood pressure is more than equal to 140 and or diastolic blood pressure is more than equal to 90 millimeters of mercury on 2 occasions 4 hours apart in a patient who was previously normotensive, and this occurs after 20 weeks of gestation. And there is no proteinuria and there is no severe features of preeclampsia. And ideally, it is a retrospective diagnosis. That means after in the postpartum period, If there's a resolution occurs within 12 weeks, means it was gestational hypertension. But if resolution doesn't occur up to 12 weeks, means it is a chronic hypertension. Now, but one thing we have to remember very clearly, that if the gestational hypertension occurs and the BP is very high, that is more than 160 by 110, we should consider it as a preeclampsia. And it has been found that 50% of the women having gestational hypertension, they will eventually develop proteinuria or end organ dysfunction, which is consistent with preeclampsia. And the progression from gestational hypertension to preeclampsia is also more marked if it occurs less than 32 weeks. Next slide. Now coming to the entity preeclampsia. Now again, hypertension, if it occurs on 2 occasions, 4 hours apart. Hypertension means systolic is more than equal to 140 by 140 and diastolic is more than equal to 90 millimeters of mercury in a previously normotensive woman with either proteinuria is present or any one condition is present which indicates the maternal organ dysfunction. So now the proteinuria, how it is assessed, earlier it was that 24 hours urine sample to be collected, and if the protein is more than 300 milligrams, we consider as proteinuria, but this should not be used now. So now what is more recommended is protein and creatinine ratio, if it is more than 0.3, or albumin creatinine ratio, that is 8 milligrams per mmols. So that is a diagnostic threshold. And the dipsticks also, it should not be used, but if it is, but other thing, if it is not available, then we can use the dipstick, and the dipstick of more than 2 plus. Now there are 6 features which indicates the maternal organ dysfunction. Maternal organ dysfunction, that means if the acute kidney injury is there, which is indicated by creatinine of more than 1 milligrams per dl, or if there is a liver involvement, which means that SGOT and SGPT enzymes are more than 40, with or without right upper quadrant or epigastric abdominal pain. Then neurological complications includes either there is a severe headache which is not responding to drugs, persistent visual scotomas are there, blindness, stroke, or there is a fits, eclampsia, or altered mental status. Then hematological complication includes thrombocytopenia, platelet less than 1.5, or if there is a DIC or hemolysis, or if there is a feature suggestive of uteroplacental dysfunction, which means if there is a FGR or any abnormal artery Doppler is there. So either of 6 feature, if it is any one is present, or if proteinuria is present with hypertension, we call it as a preeclampsia. Next slide. So whenever any antenatal patient comes, even if she is having a normal blood pressure, we should not forget to ask the signs and symptoms of preeclampsia. We should ask each and every woman if she had, or is she having the headache which is not responding to medication, or if she is finding her swelling of face or hands, or if she is gaining more weight in second trimester, especially if it is more than 1 kg per week, or if she is having difficulty in breathing or gasping or any other problem, nausea if it occurs after middle half of the pregnancy, or if there is a changes in the vision, or if there is a upper belly pain or shoulder pain. So we should not neglect these symptoms. We should take these symptoms very seriously, even if the BP is normal. Next slide, please. The next entity is the HELP. Now HELP, we all know it is hemolysis, elevated liver enzymes, and low platelet count syndrome. Now, majority of this condition occurs in the 3rd trimester, but 30% it can occur in postpartum phase also. And this is one of the severe form of the preeclampsia where the maternal mortality and morbidity is very, very high. So how to diagnose this is the, apart from the clinical criteria, if we have the test which is LDH, if it is more than 600, or SGOT and SGPT is more than twice the normal limit, or if the platelet count is less than 1, we should suspect patient has gone into the HELP syndrome. Next slide. Now, please go back. There are few atypical conditions are also present. Like if the patient, sometimes what happens, 50% of the patient, they may not have any other problems. They can just come with nausea and vomiting in second half of the pregnancy, and the blood pressures can be normal. Or if the patient comes with right upper quadrant pain and general malaise, this can be the presenting feature in 90% of the patient who are having atypical HELP. So we should not ignore these patients. So atypical HELP, it can occur in 15% of the patient, we should not forget. And these patients may not have the hypertension and even proteinuria. Next slide. Next slide. Now, next is the most dreaded eclampsia. We all know that is the preeclampsia with fits. Now, what is more important is that, please go back to the previous slide. What is more important in preeclampsia cases is that the premonitory symptoms, yes, premonitory signs, they occur only in 78 to 83% of the patients, which includes blurring of vision, photophobia, altered mental status. But in rest of the patient, they may not have the premonitory sign, and without any warning sign also, they can throw a fit. Next slide, please. Now, other entity is the chronic hypertension. Now, we call it chronic hypertension if the hypertension has been diagnosed prior to the pregnancy or before 20 weeks of gestation on 2 occasions, 4 hours apart, or hypertension which persists after 12 weeks. So, these 3 conditions, we call it as a chronic hypertension. Next slide. Next slide, please.
Malti, next slide, Raja.
Now, when we call, to call chronic hypertension with superimposed preeclampsia is that if either of the 3 conditions are present with hypertension, that means a patient that is having sudden increase in blood pressure that was previously well controlled on drugs and you require increasing in amount of doses, or if there is new onset of proteinuria or sudden increase in proteinuria in a patient with known proteinuria before or early in pregnancy, or if there is any features which indicates the end organ dysfunction prior to after 20 weeks of gestation. So in that case, we think that chronic hypertension has been clubbed now with superimposed preeclampsia. Next slide, please. Now, a chronic hypertension with superimposed preeclampsia with severe features. Now, this is one of the, again, dreaded complication of this. Now, the patient who has a chronic hypertension, and if they have the features which indicates the severity of preeclampsia, which includes if the BP has gone more than 160 by 110, or if the platelet is less than 1 lakh, or there is a altered liver enzymes functions are there. That means the SGOT and SGPT is more than twice the normal if you have the baseline value, or there is a severe and persistent right upper quadrant pain or the epigastric pain also, that has to be kept in mind. And if there are the features which indicates the pulmonary edema or cerebral or visual disturbances or new onset or worsening of renal insufficiency. So in those situations, we should think that chronic hypertension has gone with superimposed preeclampsia with severe features. Next slide, please. Now the FIGO has recommended, now 2019 and 2021 also, the FIGO recommends that all the pregnant women, they should be screened for preterm preeclampsia by first trimester. So that is either by the universal screening, but if the resources are limited, we can go for the contingent screening. Now universal screening includes the combined test. Please go back. Includes the combined test, that is the maternal risk factors, then measurement of the mean arterial pressure, then serum placental growth factor and uterine artery PI, that is pulsatility index. Now the FIGO has given the link also. So if you press this link, you will go into the risk calculators, and that risk, if it says if it is more than 1:100, that means the patient is a high risk. Now contingent screening means we have to consider the maternal risk factors and mean arterial pressure only. So with that also we can label the patient as a high risk for preeclampsia. So now the patient who are identified as a high risk, now FIGO, they recommend that we should give the aspirin prophylaxis, that is 150 milligrams starting from 11 weeks of gestation, but not later than 15 weeks, and we should continue throughout the pregnancy. And they advocate that low dose aspirin should be avoided. And then calcium supplementation also is very important, and that is 1.5 to 2 grams of elemental calcium per day. Now this has also been supported by the WHO also and the NICE guidelines, that these 2 things, calcium supplementation and aspirin, they are beneficial in preventing the preeclampsia. Next slide. Okay, this was just a video. I thought I had got it. If you press this link, you will go into the risk calculators. I think it is not getting on. So in that case, they have classified from 11 weeks to 19 weeks, and then midterm, and then late term. So accordingly, you have to choose. You can go to the next slide. I think, Malti, it is not getting on. So if you press the link, you will go into the website, and you can have the risk calculators. So to summarize this, so ultimately at 11 weeks or in the first trimester, we should screen each and every woman with the combined test, that is the medullary risk factors, mean arterial pressure, PLGF factor, and urinary and UTPI, that is a pulsatility index of umbilical artery. So if all these things says screen is ratio is less than 1:100, we call it as a negative, and patient can have the routine antenatal care. But if it is more than 1:100, then we should consider giving the aspirin to this woman. Next slide. Next slide, please. Some people, they advocated that instead of wasting the resources in all these investigations, we can straight away give the aspirin to the woman, but the risk of hemorrhages is always there. So it is always better to screen the woman and then give the aspirin. Now the NICE guidelines, that is 2023, a recent one, and also the International Society for Study of Hypertension in Pregnancy 2018. Now they have advocated that you should screen the woman with the high risk factors. That means if she has any of the 5 high risk factors, which includes previous pregnancy with preeclampsia, or chronic renal disease, or autoimmune disease, that is SLE or APLA, or type 1 or type 2 diabetes, or chronic hypertension. So if any of one is present, we should consider the patient for the aspirin prophylaxis. Or if she is having more than 1 moderate risk factors, which means if she is a preemie, or age is more than 40, or the pre-pregnancy interval is more than 10 years, or BMI is more, or if the family history is preeclampsia is there, or if she is having the multiple gestation. So if 2 of these features are present, that means the patient belongs to the moderate risk also. So these 2 categories, we should start the aspirin. But the aspirin dose they have recommended is between 75 to 150 milligrams as compared to FIGO. They say that we should use 150 milligrams per day. And then we should start as early as possible by about 11 to 12 weeks and continue throughout the pregnancy. Next slide, please. Now, coming to the other sort of interventions, like there are a lot of studies which say about the restricted bed rest, or consuming fish oils, or the folic acid, consumption of garlic, sodium restriction, or the vitamin C, D, or E. But then ultimately it has been found that they are not beneficial at all as far as the prevention of preeclampsia goes. But yes, aspirin prophylaxis and calcium intake, that is 1.5 grams to 2 grams elemental calcium, it certainly prevents the patient from progression to preeclampsia. And the few studies are there. Can you go back? A few studies are there where even the metformin, the trials are going on, and the other drug, that is a pravastatin. So these are also getting studied, but there is no final consensus has come. But a few small studies, they say they are also beneficial. But let us wait till the recommendation comes. So next slide. Now, preeclampsia assessment, now it is very important. Now, if we have diagnosed a patient having hypertensive disorders, especially preeclampsia, then each and every visit is very, very important. And we should not restrict ourselves in offering the admission to the patient, especially if the well-being of the mother and the baby is to be taken into account. Now, if the mother is having a high BP, if systolic blood pressure is more than 160, yes, you should admit the patient then and there. Or if the patient has come with the investigations and the investigations are altered, for example, if the creat is more than 1, or the liver enzymes has crossed 70, or the platelet count is less 1.5, or any feature of impending eclampsia or preeclampsia, or if there's a suspected fetal compromise, we have to admit the patient, evaluate, and then proceed. And we have to, how often to evaluate such patient, how often to examine them or do the clinical assessment is entirely on your hands. You have to individualize the patient. You have to have the frequent checkups. Please change the slide. Now, this is the another model which has been given by the NICE guidelines. Now they have come up with the PrEP L and PrEP S models. So they have combined both the models. So they have recommended that in the cases of preeclampsia, this model should be used so that you will know that the patient is having a high risk for the complications of preeclampsia and eclampsia. So this is a combined model. It has all 14 parameters. This is also easily available on the website. You can have the scores also. So 14 parameters includes maternal age, gestational age, reflexes, then any medical conditions, then protein to creatinine ratio, and serum urea concentration, platelet count, systolic blood pressure, then any treatment if it was taken, max self and pulse ox, what was the reading, liver enzymes, and serum creat values. So once you fill all the values, and if you press the time point, so for example 2 days, then there is about 3 days, 4 days, so exactly you will get whether a patient is high risk for complications of preeclampsia or not. So less than 50% it is taken as a low risk. So those patients you can have the different kind of follow-ups and the checkups. But if the score goes more than 50%, means the patient is very much high risk and you have to have an intensive monitoring for that patient. Next slide. Next. Now, management of patient with preeclampsia, now it is divided on the two parts. If the patient is having a hypertension only or severe hypertension. So if the BP is less than 160, 110, in that case, you have to admit the patient depending upon the condition of the patient or using the risk models if it is feasible. But if the patient is having the BP which is more than 160 by 110, you have to admit the patient. You have to start antihypertensives if the BP is more than 140 by 90. This we have to remember it. And the patient, we have to have the target BP has to be 135 by 85. Now all the guidelines, they give this, that we have to maintain the blood pressure of a pregnant woman nearing 135 by 85. And how frequent the BP monitoring has to be done, it depends upon whether you are having the non-severe or a severe. So if you are having a patient who has a severe hypertension, every 15 to 30 minutes, you have to do the blood pressure till the blood pressure comes to less than 160 by 110. And then at least four times per day, you have to monitor the blood pressure. Now the dipstick proteinuria you don't have to do every now and then. It is indicated only if there is a new symptom or the sign it occurs. And blood test, especially the CBC, LFT, KFT, it has to be done twice a week if you are dealing with non-severe preeclampsia. And if you are dealing with severe preeclampsia, it has to be done every alternate day. Now the fetal assessment with the ultrasound and biophysical score, you have to individualize, but not more than every 2 weeks it has to be done, and Doppler studies has to be done. Next slide. Now the drugs which are recommended for the hypertensive crisis are 3 drugs, that is labetalol, hydralazine, and nifedipine. Now the main objective of using these drugs is to prevent the complications of severe hypertension, which includes congestive heart failure, myocardial infarction, renal injury or failure, and ischemia. So labetalol, now the IV dose has to be used if the patient is having hypertensive crisis, which means more than 160 by 110. So you start with the dose of 10 to 20 milligrams, and then after every 10 to 30 minutes, you repeat the dose. So in such a way, like if you have used 20 mg, then you go to 40, then 80. So in 24 hours, the dose should not cross 300 milligrams. That is the upper limit. And labetalol, it has an onset of action is very quick, within 1 to 2 minutes. But we have to be very careful in giving the it has to be avoided in asthmatic patient or if the patient is having other heart complications. Now, once the patient has been stabilized with these drugs, then we go to the expectant management. That means you can start orally. Now, labetalol, you can start orally and you can go maximum to 2400 milligrams per day. And even the nifedipine can also be used. And if at all methyl dopa is present, then you can use that. So the choice should be labetalol, nifedipine, and then methyl dopa if it is available. Next slide. Now that when to deliver such patient is very important, the patient having preeclampsia. So our aim is to prolong the pregnancy if it is possible at 37 weeks. And once she has reached 37 weeks, we should terminate the pregnancy in next 24 to 48 hours. But in some cases, we have to plan the early birth in cases if the patient is having the severe features of preeclampsia. And in that case, we have to involve the senior obstetrician, anesthetist, also neonatologist also, and we should consider the IV magnesium sulfate and also the antenatal corticosteroids. Now, the severe feature includes if you are unable to control the maternal blood pressure despite 3 drugs and in the appropriate doses, that is one. And second, if the pulse ox says saturation is less than 90%, or if there is a deterioration in the biochemical test, that means the liver function test, kidney function, or if there's evidence of hemolysis or the low platelet count, or if any neurological features are present, or if the baby is getting compromised, means if there's a non-reassuring cardio CTG or a reverse end-diastolic flow, anything in that case, we should plan the early birth. Next slide. Now, if you are terminating the pregnancy and you are taking the patient for cesarean section, so in that case, now choice of anesthesia also is very, very important when we are dealing with hypertensive diseases. Now, general anesthesia, definitely it carries more risk than the regional anesthesia. Why? Because the risk of aspiration is there, and also there can be the edema which is present in the pharyngolaryngeal area. So failed intubation can also be there. And next, in that case also, patient can also have the stroke, which can be secondary to increased systemic or intracranial pressures at the time of intubation and extubation. So the choice should be epidural or spinal, which is acceptable. And the risk of epidural hematoma, we should not think if the platelet count is more than 70. Next slide. Next slide, please. Now, another consideration is the magnesium sulfate. Now, we all know that magnesium sulfate, it has the anesthetic implications and it prolongs the duration of non-depolarizing muscle relaxant. So, should we stop magnesium sulfate if we are taking the patient for cesarean section or not? So, the answer is we should not stop the magnesium sulfate. We should continue. Why? Because we all know that Maxilf, the half-life is 5 hours. And then the discontinuation of infusion of Maxilf before cesarean delivery will only slightly decrease the magnesium concentration at the time of delivery, but the possibility of risk of convulsion is increased. Why? Because at the time of induction of GA or any stress and also the stress of delivery also. So in that case, the threshold for convulsion is decreased. So the patient may have fits. So in that case, what is recommended? We should not stop Maxilf when we are taking up the patient for cesarean section also. Next slide, please. Now, if we are delivering the patient, now intrapartum care is again very, very important. BP monitoring we have to be doing very frequently. Antihypertensives has to be continued. But what is more important, do not give the preload to the women who are having the severe preeclampsia, especially with IV fluids. And we have to shorten the second stage of labor. Next slide. Now, what are the indications for magnesium sulfate? Please go to the previous slide. Now, when do we start the magnesium sulfate in the cases of hypertensive disorders? Now, if the patient is having a severe hypertension, that is 160/110 blood pressure is there, or if she has thrown a fit, in that case, we have to start. Or if a patient is having one or the more of the following features, which are if she is having a recurrent and the severe headache, if she is having visual problems, or if she is having nausea and vomiting with raised blood pressure, epigastric pain, oliguria, in that case, and also if the biochemical tests are deteriorating. So in those cases, if more than the one features are present, we should consider giving the magnesium sulfate, even if the BP is less than 160/110. Next slide. Now, there are various magnesium sulfate regimes are available, and but what is usually people are giving is a Zuspan regime, where we give the loading dose of 4 grams IV, and either we can go for the IV infusion if it is available, but otherwise what is more practical and what is more easy is that you give the loading dose of 4 grams, that is IV infusion, and also give the IM injection that is 10 grams, 5 grams on each buttock, and then you continue 5 grams on alternate buttocks every 4 hours for 24 hours. And there are various preparations also. Pre-prepared formulas are also now available of different brands are also available. Now for the peripheral health worker, we have to tell them, if they are not able to establish the IV access, that is a venous access, if it is a problem because of the edema or because of any other challenges, so in that case they can start with the IM doses. They should start with the IM dose, give the 10 grams, 5 grams on each buttocks, and then continue the same regime. That means they can omit the IV regime and they can start with the IM regime also. This will also help these patients. Next slide. Monitoring the patient on magnesium sulfate is very, very important. We have to frequently monitor the pulse, BP, reflexes, and urine output. Next slide. And there are few conditions that where the magnesium sulfate is contraindicated. We have to rule out those conditions, although it is not very common. Example, myasthenia gravis. Please go back to the previous slide. Myasthenia gravis is the one condition, or if the patient is having heart problem, that is ischemia, heart blocks, and if there's a hypocalcemia, or if the patient is having moderate to severe renal failure. So in these 4 patients, we should not give magnesium sulfate, is absolutely contraindicated. And then we should prefer using the phenytoin or benzodiazepines. And whenever we are giving the magnesium sulfate to the patient, we should always keep ready 3 things by our side. One is the tracheal intubation set should be available. Calcium gluconate should be there, which act as an antidote, and the IV furosemide should also be there. Now the therapeutic range of magnesium concentration, we all know it is 5 to 9 milligrams per DL. Next slide. Next slide. So when do we call the patients that they are refractory to magnesium sulfate? Please change the slide. So if the patient is having more than 2 episodes of convulsions on magnesium sulfate, or she's continuing the convulsions after 20 minutes of the bolus, so we should think that the patient is refractory to magnesium sulfate. Next slide. So in that cases, yeah, please go back to the previous one. Yeah. So in such cases, now if the patient is refractory to magnesium sulfate, so in that cases, patient, if she is throwing a fit despite this much dose, we should give the additional 2 to 4 grams magnesium sulfate IV over 5 minutes. We should call for help, call anesthetist also, and the physician, if they are available, take their help, use the alternate drug. And because a patient may require intubation, and then also think other conditions also, and don't forget to do the head imaging in such cases. Next slide. Now, postnatal management of preeclampsia women also is very important. Now, the women who were not on previous any antihypertensive treatment. So those patients in the postnatal or the postpartum period, we should start the antihypertensive if the BP is more than 150 by 100. This is different as compared to the antenatal period. Now, antenatally, if the BP is more than 140 by 90, we should start. But in postnatal, the cutoff is 150 by 100 millimeters of mercury. And BP monitoring has to be frequent and depending upon the case. Now, if the patient was on antihypertensive previously during during antenatal period, then we have to reduce the dose if the after delivery the BP is less than 140 by 90. And certainly we have to decrease the dose if the BP is going below 130 by 80. Now, the patients who were on methyl dopa antenatally, we have to stop methyl dopa in next 48 hours and switch over to another drug. Follow-up of these patients is very, very important. We have to call them frequently if they are on drugs. But the routine follow-up should not be forgotten. That is after 2 weeks, 6 weeks, and 3 months. Next slide. Next slide. Now, there are other 2 entities which are common in the cases of severe preeclampsia and eclampsia. The one is the PRES, that is the posterior reversible encephalopathy syndrome. Now, here the patient who are having, who are preeclamptic or eclamptic, now they will continue to have the neurological signs and symptoms. They will have a vision loss, headaches, convulsions, altered sensorium. It takes a slightly longer course. So the MRI is diagnostic for such patients. Next slide. And the other condition is the reversible cerebral vasoconstriction syndrome. Now here the patient, they typically have the thunderclap type of headache often, and they also have the focal neurological deficits, and they also have repeated convulsions and stroke also. So these 2 conditions, now they have a poor prognosis, and the course also is prolonged in such cases, but ultimately how to manage is depend upon go back to the previous slide. Yeah. So management is simply the supportive treatment to these patients, which includes a control of hypertension and anti-epileptic drugs and to control the neurological complications. And some patients, they do recover from such conditions. Now, another thing is the gestational hypertension. Now, this is another very important condition, because these patients also land up with preeclampsia and the complications. So we should not miss these people. Now, gestational hypertension, now the monitoring and the giving the drug is same. That means you start the antihypertensive if the BP is more than 140/90, maintain the BP around 135 to 85. But the dipstick proteinuria is very important. Now you have to consider doing the measure the proteinuria once or twice a week, so as to know that patient is not heading towards preeclampsia. But if the patient is having a severe hypertension, that is more than 160/110, then daily proteinuria has to be checked. And the blood test has to be done. Again, CBC, LFT and KFT should be done on weekly basis. And other thing is that in the cases of gestational hypertension, we should consider the PGF also. Now this has been recommended. I have already spoken. It is recommended by NICE guidelines also. That is a placental growth factor. Blood testing has to be done at least once if we see the patient, so as to rule out whether she is not heading towards the preeclampsia. And then fetal assessment has to be done every 2 to 4 weeks or every 2 weeks, depending upon if she is having the severe hypertension. Next slide. Now, timing of birth in the cases of gestational hypertension also is important. We can plan delivery at or after 37 weeks. And if the patient who was on antihypertensives and she was having the gestational hypertension, again, in postnatal period, we have to reduce the dose if the BP is less than 130/80. And if the BP is more than 150/100 postnatally, we have to consider starting the antihypertensives. Next slide. Eclampsia, the management is very, very important. Always call for help. We have to resuscitate the patient, control the convulsions, use the magnesium sulfate, investigations, antihypertensives, and plan the delivery. Next slide. Now, HELP syndrome, it is another one extreme where the maternal mortality and morbidity also is very high. Here we have to deliver the patient regardless of the gestational age. Now, very close monitoring of such is very, very important. Now, if suppose the patient has the liver enzymes which are in the range of more than 2000 and LDH is more than 3000, we should think the patient is having a high, very high risk for mortality. So these patients should not be missed, and they have to be managed in the tertiary care with proper multidisciplinary approach. Next slide. Now, in the cases of HELP syndrome, now usually the postnatally, they have a peak. Now, the peak deterioration 2 days after delivery, but after 4 days, they start recovering. So if you have a patient whose platelet count continue to fall even after the 4th postpartum day, think it is not a HELP, it is something else. Usually the HELP syndrome people after delivery, they recover. Next slide. Now, there are various differential diagnoses of the HELP syndrome, but especially if it is a acute fatty liver. Now, it is very important to differentiate. Now, if the patient is having a jaundice and she is a case of HELP syndrome, so in that case, always the dilemma is there to differentiate it with the AFLP. Now, as you can see in this chart, almost all the features are matching in both the conditions. But what is absent is that in the cases of AFLP, usually the patients are not anemic. But then in our country, usually the people are anemic, so we don't have to include this. But other thing is that the hypoglycemia, that is one thing, and increased ammonia level, that goes in favor of fatty liver of pregnancy. So this is how we clearly differentiate between HELP and AFLP, especially if they have the jaundice also. Next slide. Now, preconceptional management is very important if the patient is having the chronic hypertension. Now, if she is planning for the pregnancy, then she has to know her target BP, which is again 135/85 before she starts planning for conception. And if she is on ACE inhibitors, or if she is on angiotensin 2 receptor blockers or thiazide like diuretics, we have to tell her it is a teratogenic, and we have to switch to the alternative management. We have to take the consultation of the physician also. And her target in any she has to have at least 2 to 3 months of the normal BP before she start thinking of the pregnancy. And again, aspirin has to be considered, and placental growth factor testing should start from 20 weeks till 37 weeks, so as to rule out the preeclampsia. So this is the recommendation of NICE 2023 for the patient who are planning the conception. Next slide, please. Now, a word about the placental growth factors. Now, it has come up a lot, this testing, but this test should not be used alone. It always has to be used along with the clinical assessment. Now, there are the 3 types of the tests which are included in this category. That is the PLGF, that is a placental growth factor 1, 2, 3. And then the ratio also, that is a soluble FMS like tyrosine kinase 1 and the placental growth factors. And then next is a tri-age PLGF test. So this test, if we are using, it has to be done only once. It should not be repeated. There's no clear-cut guidelines about it, but yet we fall in the Asian population and we are the high risk, so we should consider doing this test. Next slide. Now, how the Indian lab, they have, okay, so these are the cutoffs. Yeah, these are the cutoffs for the different tests. So next slide. Next slide. So now our lab now patients, we get like a preeclampsia prediction panel. This is one of the reputed lab, how they interpret the result. So they give the ratio of these two, PLGF and soluble FMS like tyrosine kinase 1. So if this test has to be started from 20 weeks and only once it has to be done. So if between 20 to 34 weeks, as you can see in this, if the value is less than 38, and also after that, that means the patient will not develop preeclampsia in next at least 1 week. So that is, it rules out. Now, and suppose if between 20 to 34 weeks, if the test is more than 85, so it certainly says that patient is a high risk for the preeclampsia, and there will be early onset within next 4 weeks, within next 1 month. And if she is between 34 weeks or to 37 weeks, that means she will have the late onset of preeclampsia if the value is more than 110. So this is how it is interpreted, and this is quite useful also. Next slide. So now to validate this test, now the study has been done, a prognosis study which has come up, and they say that the negative predictive value of this test is very good, that is 99.3%. And sensitivity is 80%, and the specificity is 78% of this test. Next slide. Now, the long-term consideration of this patient, we all know the complications of preeclampsia and eclampsia because it involves each and every organ. It damages each and every organ of the mother, and also the baby also is at the risk. Now, there are long-term complications also on the woman who has suffered the preeclampsia. Even after, if there is a resolution of the symptoms also, then also the patient is at a future risk of cardiovascular, neurological, and other complications. And it is said that even the children who are born to the preeclamptic women, they also suffer from the long-term complications of cardiovascular, respiratory, neuropsychiatric, GI, and endocrine morbidity. So they have to be kept under surveillance and examination. Now, it has been found that there is a linear association between the severity of preeclampsia and the risk of future cardiovascular morbidity. That means the severe the disease, the high risk for cardiovascular morbidity. Similarly, if the preeclampsia has occurred in 2 pregnancies, then also they are at a high risk of the future complications compared to if the preeclampsia has occurred in the first pregnancy and single pregnancy. And also the women who have preeclampsia in the first pregnancy, they have a 4-fold increased risk of end renal damage in the later HYPE. Although the risk was found to be less than 1%, but still the risk is there in next 20 years. Please change the slide. And then eye complications are also high in the preeclamptic women. And also there is again a linear relationship between the severity and the eye complications in such women. Next slide. So the follow-up of these women, again, long-term follow-up is very important. Now, FIGO, they recommend that these women in the postnatal phase, they have to be monitored. But even after that, also after the 6 weeks to 12 weeks, they should be followed up. And then after that, annually, they have to be followed up with the history and physical examination, blood pressure checkups, and also to screen for the cardiovascular risk factors and the diabetes also, because they are more prone for such complications. Next slide. And ACOG recommends that we should annually screen. Please go back to this. No, please go back. ACOG recommends that annually we should follow preeclamptic women with blood pressure, serum lipids, fasting blood sugars, and BMI. So we should keep on following such patients for a long time. Now, next, now with this, I conclude my talk. I'm not going to repeat what I have already spoken, but this is for the audience. Let us quickly revise. Malti, slowly, answers are also coming. So the target BP antenatally is?
130 by 80.
Yes, 130 by 85.
135 by 85. Cheating we have done.
Next, when do we start the antihypertensives? At what blood pressure?
140 by 90.
190, yes.
140, 90 or equal to.
Yes. Next slide. Okay, so which pharmacological agent is role to prevent the
Aspirin and calcium.
Yes, and calcium. Next.
Dose भी याद रखिए.
What is the definitive of preeclampsia?
Delivery.
Yes. Next, everybody. Next. What is the primary objective of management of preeclampsia?
Prevention of complications.
It is always a maternal safety. Prevent the maternal complications first. What is the secondary object? Fetus. Yes. Next. So we have to fetus, that also we have to remember one thing, that we have to give a mature enough fetus so that the baby should not have a prolonged nursery care and this. Now the decision when to deliver the patient again is very important. So this has been recommended by all the bodies. That is a nice FIGO and ACOG also. So if a patient is having a chronic hypertension, not on medication, terminate at 38 weeks. Chronic hypertension controlled on medication, 37 weeks you should terminate. Chronic hypertension which is not well controlled or on medication, 36 weeks you should consider terminating the pregnancy. Gestational hypertension at 37 weeks. Preeclampsia without severe feature, again 37 weeks. But if preeclampsia or the gestational hypertension with severe features, don't go beyond 34 weeks. And preeclampsia with severe features, unstable, complicated, then you have to take the decision then and there. Maternal safety is the first thing. Next slide. So these are the references from where I have given my lecture today. And thank you so much for the patient hearing. And once again, I thank the Delhi Gynae Forum for giving me the opportunity. Thank you, Sharda Jain, Madam, Dr. Renu Chawla. And my regards to all the respected seniors and the colleagues who have joined today. And my regards to the chairpersons of my session. Thank you so much.
Very nice.
In every aspect of hypertension, so meticulously. I hand over the rise to ma'am for her expert comments.
I will say that, I loved it the first time she had presented, and this is the second time she's presented. There's nothing left for me. And what I can only just suggest that I've seen best of both worlds. And eclampsia, everybody will say that, it can be prevented completely. But now I can say that in case if you do an antenatal screening for hypertensive disorders of pregnancy, right with your first trimester screening, then I think the severe PT can also be prevented. I find that in the last 10 years, people like us have not seen it. So I think it is totally, these conditions can be reversible, provided you are very careful about it and each patient requires attention. So I will say that I am in practice for the last 32 years now. No eclampsia. And now in the last 10 years, I could say no severe PET.
Thank you, ma'am. Dr. Anita, your comments, please.
Thank you so much, Richa, for that wonderful presentation. I think you have not left any stone unturned as far as hypertension and pregnancy is concerned. As far as Sharda ma'am has highlighted that she has, fortunately not encountered eclampsia. Very true, ma'am. The incidence has really gone down. But one thing I wish to say is that there may be complacency on the part of obstetrician when delivery happens. We must remember that BP charting is very important in postnatal phase also. I have seen in my hospital only so many postpartum eclampsia, they were normotensive. Just be vigilant about their symptoms, especially if the mother is giving you history of headache, or she's having some respiratory distress, or she's feeling dizzy. So these are very simple symptoms which will guide you. And if the patient is having edema, all these patients have to be carefully monitored even in postpartum phase also, because we must remember that 30% of eclampsia are postpartum eclampsia. And Richa has very rightly highlighted the importance of hypertension in pregnancy related to development of non-communicable diseases later on. It is very rightly said that a severe preeclampsia can cause premature death by 10 years of that particular mother if the attention is not given. And we must be careful about these subtle symptoms during pregnancy. Like we don't pay much attention to even nausea, vomiting. Nausea, vomiting happening late onset in later half of pregnancy, or patient is having blurring. All this we have learned, but we don't pay much attention to nausea, vomiting, difficulty in respiration. So we must be very, very, particular about these symptoms. And SLFT plus growth factor is very important. It is coming in a big way. Less than 38 ratio will convince you that patient will not have any problem at least for next 7-10 days. So we must know how to, do this triaging with placenta growth factor, as she has very well highlighted. One thing I wanted to say is a new thing coming up is ophthalmic artery Doppler. So some of the studies were being done regarding prediction value of this. So I don't know what is the current status, but it is still under consideration. When we use Mexel, one thing we must remember is interaction with other drugs. Suppose your patient was already on calcium channel blockers. So please be vigilant, because the toxicity of magnesium sulfate may happen with these calcium channel blockers and other drugs which may, some hypnotics or some sedatives. The thing can also increase the toxicity value of magnesium sulfate. As far as chronic hypertension she had discussed, I just wanted to say she's very rightly highlighted preconception counseling is very important. She should be having normal blood pressure at least for 2-3 weeks before she embarks on pregnancy. Another thing is end organ damage should be assessed in these women. We should know what is the damage which has been done to her eyes, her kidneys, her liver, what is the status of her heart. So all these things have end organ damage has to be assessed before we advise or allow pregnancy in such patients. So these were the few comments I wanted to add. And thank you, Richa. Congratulations to you. It was wonderful. It was a full treatise on hypertension in pregnancy. Thank you. I have also learned many things. Thank you so much. Thank you, Sharda ma'am, for this beautiful presentation you have got from Richa, Dr. Richa. Thank you, ma'am.
Thank you so much, and thank you, Sharda madam, for giving me the opportunity.
More who have to give comments, and I can only just say one more thing. I will add it, that don't hesitate giving in severe PET max self. I think once you started, you have to continue it for 24 hours. Please, other people are there for experts.
So I would like to add, ma'am, that the WHO advocates the inverted pyramid of antenatal care. It focuses on 11 weeks to 13.6 for risk stratification. We all know that we do screening for aneuploidies during this time. We do screening for preeclampsia. We do screening for preterm delivery by assessment of cervical canal length. So basically, this is a period which is focused and it is in inverted pyramid of antenatal care, that more focus should be done in this period so that we can stratify the patient into low risk and high risk. And Dr. Richa has wonderfully covered the entire topic. All the aspects have been covered, and we had conducted a thesis. I had conducted a thesis, and we did a comparative study of SFLT1 with placental growth factor versus uterine artery Doppler in prediction of preeclampsia at 20 to 24 weeks of gestation. And we also found that the ROC curve analysis, the highest area under curve was for this SFLT factor. At this month, the ratio was very important. If the cutoff was less than 38, if there was less than 5% patient developed preeclampsia. Basically, there are two important roles of this ratio. First is prediction of preeclampsia. Second, if it is done in diagnosed patients with preeclampsia, it assesses the severe adverse outcome. So we did for prediction, and we compared it with uterine artery Doppler. So we found that this ratio is better as a predictor marker. Secondly, if we do it in a diagnosed case of preeclampsia, it definitely gives us a value implication that within 7 days, there are more chances of adverse outcome if the ratio is more than 85. Patient needs more intensive monitoring, patient might need delivery, and whereas if the ratio is less than 38, patient can be managed outpatient. There is no need for inpatient, no more monitoring. So definitely this will be a promising marker, and in coming time, this will be used, but presently it is costly. So this is all I wanted to add. This was a thesis which we did.
Now, I will just tell you about the screening part and how much does it cost. As far as the aneuploidy screening is concerned, all very good labs give you 3,000 rupees. But if you combine with PET, now to all people in East Delhi, they are giving you 3,000 rupees. So never ever hesitate to get the PET screening done. We've been doing it for many, many years now. No increase in charges.
Yes, ma'am.
Can I speak, ma'am?
Please.
Thank you, Dr. Richa. I think it was very well summarized. In such a short period, you have explained everything about hypertension in pregnancy. I wanted to say, as Madam said, that we have been acknowledging that as GDM is increasing day by day, the PET is slowly decreasing. It may be, I don't know about government hospital, but maybe our patients are from urban areas and from well-to-do families, but they must also be observing that it is decreasing. So I wanted to ask, any role of magnesium and preconceptional aspirin. If one pregnancy she had severe PET and she is planning for the next pregnancy, can preconceptional low dose aspirin can be given or not?
That can be given.
Preconception is basically advocated in patients with APLA. Diagnosed APLA में हम देते हैं preconception. So it may be very well given in patients who are at high risk for preeclampsia. But all the guidelines say that if the patient is high risk for preeclampsia, she should receive aspirin from 12 weeks, definitely before 16 weeks. So this is the
after pregnancy. I'm
those
asking
should be
about preconception.
150.
150. Any role of magnesium?
Magnesium as a salt.
Yeah, oral magnesium.
No.
Guidelines evidence-based medicine.
Now she's supplementation of and magnesium.
Oral magnesium
I have
supplement.
started. Can we have one by one? People like me have started. I give them in the 4th month. I give them in the 7th month. And in case if the PET has not occurred, then I will hold it on. But I think in 9 months' time we will give it to her for 3 months. I just want to repeat, our severe PET has disappeared.
Ma'am, we still have many patients, ma'am.
Unique class of patients, ma'am. मैम आपके पास बहुत unique patients आते हैं.
जी मैम.
As far as magnesium is concerned, they say that there are certain compounds of calcium which have magnesium integrated in that. So it says that it helps in prevention of preeclampsia. Yes. There are certain preparations.
Few studies are
Last word is Richa. Last word is Richa. Richa has said that as far as the prevention part is concerned, aspirin and calcium dosage is 1.5 to 2. अभी और कुछ नहीं आया डॉक्टर साहब. और आप कुछ भी करते जाओ, वो आपकी मर्जी है.
Dr. NEERJA?
Yeah. Hello. Yeah, it
Yes,
was
yes,
an
we can hear
excellent
you.
presentation, and Richa has covered most of the points. Everything has been covered. I just want to, like everybody has emphasized, inverted pyramid, the role of we were using uterine artery Dopplers. Now the PLGF has come in a long way, and it will really improve our prediction for pre-eclampsia. I just want to emphasize 2 or 3 points that taking the protein creatinine ratio and albumin, the second urine sample is to be taken, not the first urine sample. That is very important. And we have to know that sometimes that SGOT rises earlier than SGPT. If we are seeing the rise of SGOT earlier, then we can predict that patient is undergoing, she may land up in PET. And we have seen that patients who is not having proteinuria, they have more severe disease. They land up in more of the hepatic dysfunction, and so we cannot just emphasize on proteinuria. So we have to see that the patient who is not having proteinuria, they are also having a lot of problems. And like in PNC postnatal cases, everybody has emphasized that we should not be taking ACE inhibitors and ARB, which we started during chronic hypertension treatment of the patient. If a patient goes on prolonged magnesium sulfate treatment, then also we have to monitor the children because they may land up in hypocalcemia and hypermagnesia, and sometimes the child becomes very lethargic and drowsy, and all these shows that child is going into hypertension. These are just a few comments I just want to add. Otherwise, it was an excellent presentation. We learned a lot, and it was really very good.
My request to everybody is what she has updated it till 23, including the nice guidelines. आपका काम है adhere करना. आप अपने इस दिमाग को काम करना कम कर देंगे. जो रिचा ने बोला वही बात मानेंगे.
Dr. Seema Gupta.
Yeah. Thank you, Dr. Richa. It was an excellent presentation. Learned so many new things. The first trimester screening is very important. Universal screening especially. So if we find any of the patient which is high risk in the first trimester screening, we should be starting ecosprin so that the complications can be prevented. And more so, the postpartum follow-up is very essential. Patients are lost to follow-up after delivery. So we have to emphasize and counsel the patients that postpartum is very, very important to prevent the future complications in the mother especially.
Dr. Preeti?
Yeah. Thank you, ma'am. Thank you, Dr. Sharda, ma'am. And definitely, Dr. Richa, it has been a very nice, very informative, and very, I think, elaborate presentation. I don't think any point has been missed. In fact, we have learned so many new things. Basically, I would just highlight the preeclampsia prediction panel. These were definitely new things for me when I was reading also, and plus ma'am has again reiterated that the soluble FMS tyrosine kinase, I was not knowing about this, and the PLGF ratio. This ratio, if in case it is less than 38, then you need not worry at all. In fact, there is no need of admission, and the patient can be, you can just keep a track of the patient. But if this ratio is 38 to 85, then you have to be vigilant and you have to definitely monitor the patient, but there's no need of admission. But if this ratio is more than 85, then definitely you need intensive monitoring and the patient has to be admitted as well. And if in case it is more than 110, then you have to be very aggressive in the management. And another new thing which I learned was this is definitely very useful as far as the predictive value, 99%. So if in case we can do it, then definitely if the score is definitely less than 38, that means within 1 week or within 2 weeks, there is no stress of patient developing preeclampsia. Then the other thing is, if in case you have, there was, when I was just reading, I just came across Justosis score 2019, FIGO Justosis score, that if in case mild is, if the score is less than 1, moderate is if the score is less than 2, and if the score is 3 or more than 3, then the score is severe. And the characteristics are, then the maternal characteristics, then if the, like if in the primary, then primary you give the score as 1. There's a whole table, the FMF table is also there for the Justosis score, and according to that we can just judge the high risk population. If in case there is a predictor of preeclampsia, then definitely you have to start the prophylaxis of this aspirin, as the aspirin trial, and this is 150 mg bedtime. Every night you have to give, starting from 11-12 weeks of pregnancy until 36 weeks of pregnancy, and calcium also 1.5 to 2 grams at least. And there's no role, they say, of vitamin C or vitamin E and the other things. This is, I think,
Thank you, Dr. Preeti.
Yes.
Thank you, Dr. Preeti. Dr. Meena, are you there? Dr. Umarai, ma'am? I think they are not there. Gestosis score is of utility because it is a clinical score and we don't have to depend on the tests.
Yeah.
Expensive tests are not required. So I think
it is indigenous. Gestosis score was, devised in India only.
Yeah.
And another
Yes,
thing of relevance is that when we were postgraduates, we were taught that if
Yes, ma'am.
the OTPT are more than 3 times raised, we alarm. But now it is any raise up to even twice.
Twice
You should
the
be
raise.
careful. So that
is
means 40
important.
40 is the limit.
Twice,
अगर
yeah.
80 से बढ़ रहा है दोनों OTPT में से कोई भी तो बस एंटीनाज अप करने हैं बिल्कुल.
Yes.
Thank you, Richa. Thank you, everyone. Thank you for involving us. Thank you,
Thank you,
Renu ji,
ma'am. Thank you.
Sharda ma'am.
Thank you, everyone.
Thank you. Thank you.
किसको ECG करना आता है? जिनको ECG करना चाहते हैं, they can get out. Otherwise, I am going to teach you how to do ECG. चलिए. Just 1 minute.